Hi, I'm David Reiss, Dr. David Reiss. I'm a psychiatrist, and I'm happy to be with you today to discuss a rather challenging issue of TBI and mental health crises in terms of identifying the issues, treating the issues, understanding the issues, and understanding what we don't understand about the issues. I just want to make it clear I'm not a neurologist, I'm not a neuropsych. But I have been working with CLF for probably over a dozen years. And just real quickly, my first sports medicine and concussion work was in medical school with the Northwestern team of 77. So that goes back a couple of years. And since then, I've been working with CLF. I also have a workers' comp practice where I see a lot of people with head injuries of various types, mostly occupational, obviously, but also people who've had prior head injuries that were never identified. And I have to bring that in to understand what's going on. Just one small vignette, rather poignant. Um, Back about 7, 8 years ago, I was at the CLF annual gala, and I met one of the players who was on the football team that I had worked with back 40 years previously. And he didn't remember me, I remembered him. But we spoke. He remembered the name of the team doctor, Dr. Reed. He remembered the name of the orthopod. We had a very nice discussion. He seemed very intact. Came across him about 20 minutes later, said hello. He did not remember us having met 20 minutes before. So that's the type of issue we're dealing with. It's difficult, painful, times tragic and sad. There's a lot we don't know, but we're learning more and more. Basic information, Northwestern Medical School and undergraduate, Ohio State, UCSD out here in California. And just in regards to my work with comp work, I've probably evaluated 15,000 people with stress claims. Many of those involve physical injuries, and a good number involve head injuries, either repetitive or single TBIs. But also even in situations which are totally unrelated, such as harassment claims, etc., you have to take a history to find out if there might be something going on that's related to a past head injury. And that has come up any number of times, both in my work with comp work and in my general psychiatric work, particularly in hospital work. We'll get into that a little bit more later. No disclosures of any type. Here we have some definitions. I'm not going to go through these in great detail, but obviously TBI and concussion are a spectrum. And as it says that, concussion is basically a relatively mild TBI. That doesn't mean the symptoms are necessarily mild. It just means that in a sense, the visible brain damage is mild and often cannot be detected by tests, by EEGs, by MRI, but the symptoms can be severe and long lasting. We generally say that a post-concussive syndrome or persistent post-concussive syndrome goes beyond 1 or 2 months. It's very individual. I've seen people where symptoms clear in a couple of weeks. I've seen people where symptoms totally clear within maybe 4 to 6 weeks. And then I've seen people 2, 3, 4 years later where they're still having very complex symptoms. CTE, of course, is the chronic disorder that we can't really diagnose clinically. I certainly don't make that diagnosis. Where that comes most into play with what I'm dealing with psychiatrically, particularly in people who've had multiple concussions, is that generates a understandable and realistic fear of their prognosis for their future. And as we'll go into, that obviously can affect anxiety, depression, functioning, and even to the extent of suicidal ideation. PTSD, I'm just going to mention at this point in that there are two particular aspects to this, which is somewhat different. One is PTSD that may be related to the circumstances that cause the TBI. The other is pre-existing PTSD that may be due to any number of different situations, basically any situation that elicits a fight or flight response that's sustained. And as we'll talk about, the neurological and the psychological aspects of a TBI can reactivate prior PTSD that may or may not have been symptomatic before the injury. ADHD, ADD, I think it's important to mention that because the symptoms of post-concussive disorder, ADHD, ADD, can be very similar. And when I put here maybe acquired due to brain trauma, I'm not going to go into the weeds as to whether that really should be diagnosed as ADD, but it looks the same. The person experiences it the same. And to some extent, the same medications may or may not be helpful with some exclusions. So it's an important issue to look at. The other thing that I don't have down there, but actually goes in line with that in terms of other things that affect concentration, memory, etc., that's very prominent these days, marijuana use, which, especially with the athletes I work with, it's pretty universal. And particularly, as I'll also mention later, since people with ADHD, ADD tend to go into certain professions, whether it be sports or other more physical as opposed to cognitive professions, they may be more likely to suffer TBI. So you're going to have a higher percentage of ADD, pre-existing ADD in TBI patients. The data on that isn't very good, but there's some studies regarding athletes that show anywhere from 20 to 50% more pre-existing ADHD, ADD in athletes at a high school, college level than in the general population, probably because those kids will gravitate towards more physical activities since they're struggling more cognitively. OCD also, there's formal obsessive compulsive disorder. I'm not really going to focus much on that as much as obsessive compulsive traits or defenses, which, as we'll get into, can certainly be triggered, exacerbated, and be very problematic in TBI cases. And then obviously other medical conditions run the gamut, both psychiatric pre-existing issues and other medical neurological issues. And one issue that I'll mention specifically that often isn't particularly looked at is pain, chronic pain, which may be due to minor injuries or maybe due to just, wear and tear. But often how a person deals with pain, what pain they're experiencing prior to the injury, what their pain tolerance is, will impact how they react to the TBI. And just as a quick thing, when I'm working particularly with athletes, but anyone who's basically played contact sports, whether or not they go on in that field, I often will ask, when was the last morning that you woke up and you weren't in pain? And the most typical answer I get is sometime during sophomore year in high school. It's an issue that is significant, but often underappreciated. Obviously, all these issues overlap. And just because there isn't a check mark doesn't mean it's not possible, but what's checked off are the areas that most frequently overlap. I've already talked about some of them. I'm not going to go into detail with this, but it makes it all very complex, at times very confusing, which is the next issue I will get into in a little more detail. We know that TBIs and concussions are associated with depression and suicide. We know that's particularly severe in young people. And I mean, that's really not, if you really think about it, not particularly surprising On a neurological basis, you're dealing with a brain that's still developing and has been injured. On a psychological basis, you're dealing with a personality or a person who may have certain areas that are still somewhat immature and may not have the best coping mechanisms to deal with stresses that come out of this. So the fact that it's more dangerous, more problematic in young people is not at all surprising on both a neurological basis and a psychological basis. And just the overall effect of TBI is can be so overwhelming in so many areas, as we'll get into, that it shouldn't be at all surprising that it's very common that depression follows. Sometimes immediately, sometimes within days or weeks, sometimes not until months later, as other issues become more and more affected and are realized as being more and more affected. Particularly in Alaska, data is that TBI mortality is the highest in the nation, which obviously is significant, and the second highest rate of suicide in the nation. Of course, any individual isn't governed by statistics, but on the other hand, the treating person, the evaluating person must be aware of those statistics to understand the level of risk that you're dealing with, which may or may not result in needing to take different precautions in a particular case, but definitely require different awareness. As you see, the bottom one, that TBI-related fatality from suicide was attributed to 43% of TBI-related deaths in Alaska. That's a huge percentage and really speaks to how much the mental health issues, even if not primary to the injury, become primary to the quality of life and even the continuation of life. Obviously, if someone comes in and they're in immediate danger, suicidal, agitated, etc., I'm not going to go through all of the details. The most important thing is to keep them safe, be in a safe environment, bring in appropriate specialists to try to figure out what's going on in an integrated way. And we will look at that in more detail in a moment. And also in terms of treatment, one issue that's particularly pertinent here is that you need to do what you need to do to keep someone safe. And at times that means using medications like, for instance, antipsychotics that may help agitation, but in the long run may actually be counterproductive in the case of TBI, whether not needed or causing cognitive problems of themselves. It is not infrequent that I'll have someone come to me who was started on medication in the very early stages of the treatment of their injury, very appropriately and possibly life-saving, but no one thought to maybe reconsider it as the danger decreased or as the picture of symptomatology changed. So that it's important to realize that some of the interventions, particularly pharmacological, that are absolutely necessary and appropriate in an emergency situation may be inappropriate and counterproductive as time goes on and may need to be reevaluated in terms of stopping a medication rather than just stacking one medication to deal with the side effects of another, which as much as possible you like to avoid. I'm going to be talking a lot about complexity and how complex this issue is. And there are basically two different issues of complexity that come into play here. I mean, obviously, we're dealing with an issue that has neurological basis, physiological basis, medical basis, psychological basis, psychosocial basis. But they're the two different issues of complexity that I want to talk about. One is that complexity at times, we use the term to refer to something that's just confusing, difficult to understand, takes a lot of sorting out. um, but that with enough effort, it can be sorted out. But then you get into complexity that's more in the realm of mathematics, stochastic processes, um, complexity on a whole different level, where the interaction of factors is so complex that what comes out of those interactions may fluctuate over time, may be different at different times, may react to different stresses in different ways, and may be either inexplicable at any point in time and unexpected, basically unpredictable. So part of it is how to understand what we can understand about a complex process, and part of it is being ready to deal what cannot be understood as other than somewhat stochastic or random as a result of the inherent complexity of the issues we're dealing with. This brings us, and I don't want to belabor this point. I could go on for quite a while. We use the term evidence-based, and obviously, we want treatment to be evidence-based. We don't want it to be hunch-based or guess-based. But unfortunately, these days, the term evidence-based tends to refer to narrowly formulated, statistically based studies. And those studies have inherent limitations because you cannot do the study unless you put some limitations on the type of patients you're working with, and that inherently will leave out some of the outliers. Uh, when you look at some of the evidence-based data, it will work for the people in the middle of the curve, the people who have an average response. But the people who don't have an average response may not only not benefit from what's considered statistically evidence-based for the average person, but may even get worse. And that's not only a practical issue in terms of choosing interventions, but it's also an issue from a very practical sense in terms of the medical system. I have any number of times had to do a prior authorization for a medication that someone didn't want to authorize because they don't recognize that the diagnosis of post-concussive syndrome includes other disorders, particularly psych disorders, that may merit medication, even if not fully diagnosed. One story, which luckily didn't end tragically, was a person I had. It was in a workers' comp case, and it was a head injury, but the person was, let's put it this way, not the tightest wrapped guy to begin with. And I used a little bit of antipsychotic to basically calm him down, and it did help his agitation without any side effects. It was approved, went to renew it, and someone in the utilization review said he's not diagnosed as schizophrenic or bipolar. They're not renewing his Seroquel. While I was fighting for that, a week later, he went into his lawyer's office with a gun threatening him. Luckily, it was diffused, but if he had been on the Seroquel, that probably wouldn't have happened. So, in terms of dealing with evidence-based criteria, we have to be very careful and at times have to educate the people who are trying to impose basically just statistical algorithms on cases which we as evaluating and treating practitioners know are inherently unique because every individual is unique. There's the old saying that's attributed to Osler. It's more important to know the person who has the disorder than the disorder that the person has. That's very true, and that often is not taken into account in statistical studies. Also, I'll just say very quickly, types of evidence. There's direct evidence, obviously. There's circumstantial evidence, which doesn't prove something, but gives you a pretty good basis to make some determinations. And then you get to what legally doesn't count, hearsay, but clinically may be very useful, not as a definitive determination of what should be done, but as a suggestion. And my favorite story with that goes back to medical school. when I was taking neurology. And I was working with Nicholas Vick, who had actually written the textbook on neurology at that time. And we had a case, I don't remember all the details, but the person had a very strange, startle response. And no one could figure out what was going on with this person. Vic remembered that in writing his book, he came across a case of 50 Frenchmen in Maine who had this type of reaction. Um, Even if you, of course, we didn't have AI in those days. That was right around 50 years ago. And I think I knew Fortran. That was about it. But I actually looked it up on AI today, and sure enough, you can find it on AI, but it's not actually accurate. It says that it's a cultural issue and it's thought to be psychological. Yet maybe the data's changed, but the data we had then was that, yes, there might be cultural influences, but there was also not only a definite neurological issue involved, but that neurological issue was actually well defined in goats. You can find the disorder of jumping goats and fainting goats, which basically turned out to be the same type of pathology. Again, that's not evidence-based. You couldn't at that time look up any study to find the 50 jumping Frenchmen of Maine, but it was useful hearsay that put us on the right track. Excuse me. The other thing I want to talk about to end the discussion on evidence-based is when evidence-based studies are set up, obviously for the study to be statistically valid, there needs to be inclusion criteria and exclusion criteria. In other words, if a person doesn't have a certain cluster of symptoms, they're not included in the study. If a person has other issues, whether they be demographic, personality issues, pre-existing disorders, substance abuse, they're excluded because it wouldn't be fair, unquote, to whatever's being tested. Let's say test that medication to someone who is using drugs regularly. Well, that makes total sense in obtaining the data for the average person, but it doesn't give you any information about how to treat the person who would have met the exclusion criteria or didn't meet the inclusion criteria. That basically, especially when they get to like person like me who isn't frontline but more of a consultant for problematic cases, if the case was someone who responded in an average manner, they'd never get to me. So I'm almost always dealing with people where the statistic is interesting to know and give you an idea of what directions to look, but doesn't really pertain to that individual. Here again, some of the other issues which may take someone out of a study would be whether they speak English or not, and just practical issues of whether they are available for follow-up, which will take out of the study various people who have demographics that need to be considered but aren't. And again, just going back to my quote from Osler, when you analyze a complex problem, the tendency is to break it apart into pieces and to understand each piece. That makes sense, particularly in linear processes where A leads to B, leads to C, leads to D. Okay, let's look at A, let's look at B, let's look at C. Where it doesn't work is where A leads to B, but B has a feedback loop that affects A, which then affects C, which then has a feedback loop that affects B. So we have to, while we're taking things apart to understand the contribution, also understand that the whole is different from a sum of the parts, very simply, but often misunderstood, particularly when there isn't a good integration of care. When you have, in a sense, the blind man and the elephant, which in my workers' comp practice is probably more common than uncommon. I'll have, whether we're talking about TBIs or any types of injuries, I'll have a medical report, a psychiatric report, a psychological report, an orthopedic report, and never the twain have met. And each are looking at things from a different way. The person who's doing pain management isn't looking at depression. The person looking at depression isn't looking at pain management, et cetera, et cetera. So we need to understand the parts and the intricacies of each part that goes into the whole, but then recognize that the whole is not just the sum of the parts. Which brings us to, and obviously this is very common language, and I'm not going to go into detail, the biopsychosocial model, which simply says that anytime you're dealing with a real life person, as opposed to maybe an AI construct, you're looking at biological factors, both inherent, constitutional, and acquired. You're looking at psychological factors, just how the person functions on an emotional level, what their coping mechanisms are, what their level of maturity is, and you're looking at social issues. How does the person interact with their family? What kind of relationship do they have? Are they the breadwinner? Are they not the breadwinner? What will this do to their future? But the social not only is related to the individual, but also to society as a whole, and particularly the medical system as a whole. As I've already mentioned, that the medical system is not always set up to deal effectively with these problems. And so that needs to be taken into consideration. Another issue in terms of the complexity of what we're dealing with, which I think you'll see as I talk, is that I'll be going back and forth to some of the same issues. This is more like peeling an onion than going on an A, B, C, D chart of do this, do that, find this, find that. It's more of, okay, when we get to the next layer, let's reevaluate everything and see how this may come into play. Obviously, in terms of mental health issues, you have pre-existing issues that may come into play. But one of the undervalued issue is when the effects of the TBI may lead to interventions that were previously helpful, no longer being helpful. For instance, if someone's on a medication, most of the antidepressants we use, most of the anti-anxiety and mood stabilizers we use do cause some mild cognitive impairment. Not all, most of them do. You know, for the average person who, let's say, is seriously depressed, that's a small price to pay. And now and then forget someone's name or need to be reminded of it is a small price to pay for resolution of, let's say, dangerous or really disabling depression. On the other hand, the person who's dealing with post-concussive TBI issues is going to be exquisitely sensitive to any additional loss of cognition. So just to pick a number off the top of my head, let's say that the medication is causing a 5% loss in cognition, which is basically imperceptible in your average person. That may be devastating to the person who's already lost 30, 40% of their cognitive ability due to the TBI. Also, it's more difficult to deal with some of these issues. For instance, if someone has a substance abuse issue, you can detox them. If someone has a pre-existing depression issue, you can rearrange the medication, but you can't detox someone from the neurological effect of TBI. So it becomes much more complicated. The treatment interventions have to be more well integrated, and often, as we'll get to, thinking out of the box as to what will work at any particular point in time. I'm going to leave details about the biological issues to neurologists, who specialty that is, and neuropsychologists. But obviously, damage to the brain, whether it's detectable on an MRI, often it isn't, in mild TBIs, concussions, whether it's detectable on an EEG, often it isn't, can affect cognition, obviously, and also can destabilize emotions, both on a primary basis and somehow affecting the parts of the brain that basically work with emotions, but less well understood and less well identified is that it can disrupt the coping mechanisms that someone has. One case, and this is a case that was referred to me by CLF, was a woman who had a concussion, not sports related at all, and she had a history of trauma, but was very bright, had very good coping mechanisms, and the concussion just affected her cognition enough that everything that she had previously repressed, suppressed, minimized, and was coping with very reasonably suddenly became an acute, in a sense, PTSD that was quite perplexing unless you went back and took a history that she didn't even remember until we really got into it. And then the treatment had to deal with both the effects of the TBI, which basically cleared after about 6 months, but also the effects of having disrupted coping mechanisms, which we're now at the 2-year mark and still dealing with that. In terms of the psychological factors, here, there are so many. These are just a few of them. But obviously, the sense of identity can be affected if someone's not functioning the way they're used to functioning, if they're not interacting, if they're not thinking the way they're used to thinking, if they're not understanding. It just affects the sense of identity, sense of competency, usefulness, as well as plans for the future, worries and fears about the future, and as I just mentioned, triggering of past issues that may or may not have been active or even a subject of treatment prior to this TBI. So you have the additional issues that are added on. You have the pre-existing issues that may be unearthed or exacerbated, and you may have a disruption of the ability of the person to benefit from treatment. I've already mentioned how certain medications may no longer be tolerated, but also if a person's cognition is impacted sufficiently, they may not be able to make use of the psychotherapy or counseling that was very effective previously. And there may need to be a change in approach, and sometimes there isn't even a good approach. So psychological issues, again, are very complex, and as is pretty obvious from this, is they're all interacting. The sense of identity interacts with plans for the future, interact with how you deal with problems past, present, and future. So these aren't separate issues that, as I said before, can be taken, well, let's deal with this, let's deal with that. No, let's deal with this, let's deal with that. But then let's see how they all come together, sometimes in positive ways, sometimes in negative ways. And that may change moment to moment, day to day, hour to hour, week to week. One of the hallmarks of these kinds of disorders is that the symptoms present today, the treatment useful today, may be very different from tomorrow. And that calls for very close observation clinically and very careful integration, because everyone on the treatment team, be it neurologist, orthopedic, medical doctor, psychiatrist, psychologist, needs to know what the other person is dealing with, and any changes in the treatment, long-term or just acutely, that needs to occur outside the particular treater's area of expertise. This gets, again, very complicated, but must be considered. The social factors, basically we've already referred to because they very much are related to the psychological factors. The disruption of practical function. Can the person work, play, interact as they usually do? Are they able to use coping mechanisms, not only psychological coping mechanisms, but let's say even the person who uses exercise or running and can't do it, or he uses reading or watching movies, even listening to music, but then develops, let's say, a hyperreactivity and oversensitivity the ability to cope with even normal social situations becomes difficult, let alone disruptions of financial stability, disruptions of personal relationships because of that. Uh, if a person's younger, disruption of an education or career, direct disruptions of career paths, and very importantly, the last one, loss of independence or enforced dependency, which is particularly is significant in people who very much value their independence. And of course, this can happen with any medical issue, but when it's a less well-defined medical issue, it becomes much more problematic. It's a lot easier for someone to say, help me wash the dishes because I have an injury to my arm, than help me do everything because I'm not thinking right. So the dependency that comes along with it can affect the relationships, whether the relationship is healthy or particularly if the relationship is toxic, as well as the person's sense of self, self-esteem, and all the other issues we've already talked about. So here again, I'm just reviewing that what we're dealing with are not independent variables, but are mutually dependent variables. If you look at it mathematically, I'm not going to go into details with that. It means you can't define it by a linear algebraic equation. You have to define it, if you define it mathematically, by an equation that uses partial differential equations. And I won't begin to say what that is. Other than that leads to a chaotic or stochastic process where there may be, and most of us know about this in the pretty pictures we see, develop fractal patterns, which are repetitions of uh, certain phenomena on different levels and different time frames. But the other thing that's very technical is called strange attractors, which is when you have a stochastic system that has a certain randomness to it. For mathematical reasons, there'll be a tendency for the system to return to certain states that may not be explicable by our normal way of explaining things. It's basically a mathematical function, but there'll be certain states that are called strange attractors because they attract the system to that state, which may be positive or is often a negative pathological state that will repetitively but unpredictably recur and need to influence treatment at those times. A lot more that can be said about this, but it's way beyond my expertise. So a lot of what we're doing is treating the unpredictable. And as I've said, the very nature of the person's pathology may have excluded them from standard studies, which tell you what to do. And you're often dealing with outliers because there really isn't necessarily an average case, or the range of average cases may be very narrow. So it's important to realize that we're dealing with the unpredictable. Now, this means you have to get all the information you can, and you have to talk to the patient and the patient's family about the fact that we may not always know what to do. We may not always understand what's going on. One of the ways I found that you might think would put people off, but they generally find understandable and recognize that it's honest and are able to accept it, is I often say, look, I have a pretty long background in this, but to be totally honest, I can tell you more about what I've learned doesn't work than what I've learned does work. And that's important. That goes back to that old story that's attributed to Edison, where someone asked him, don't you regret having spent so many years, investigating so many different substances until you found that tungsten should be in a light bulb? And Edison supposedly responded, no, I now know 10,000 substances that won't cause light. It's similar. It's important to know what doesn't work as much as it's important to know what will work and to be honest with the person To be honest, when we're basically using trial and error, when we're using knowledgeable trial and error based on evidence, and that evidence may be solid statistical evidence or may just be experience. I mean, I happen to know which medications I prefer in certain cases, and I think most docs work that way. That someone else may prefer other medications, and it may just be because each of us is more familiar with the intricacies of that agent. So all of that needs to be taken into account and honestly, openly discussed. But in order to get to that point, clearly we need a full medical history. Are there previous neurological problems? Are there complicating medical problems, cardiological problems that may prevent use of certain medications? Are there standard treatments that have failed in the past that may give you a hint of what may or may not work? Clearly psychological, previous ADHD, PTSD, OCD, anxiety. And I'll just mention OCD a bit here too, because as opposed to the formal obsessive compulsive disorder, where the person has specific compulsions and has to do something or becomes very anxious, more often we're seeing in these situations people who have obsessive traits, which means that these are psychological defenses that are largely adaptive. I mean, if you find a lawyer or a doctor or someone who doesn't have obsessive traits, find someone else. It's necessary. It's adaptive. But those traits can also exacerbate and become problematic as defenses when a person realizes they're not functioning very well. One case I recently had, and this is someone who had a TBI, a rather serious TBI, but was neurologically getting better. But when I met with the person and evaluated him, all he could talk about, and no matter what questions I asked him back to it, was his urological problems. Now, I'm not a urologist. I don't know what was going on, but he was obviously obsessed with it. And I wasn't sure if that was an obsession coming out of his attempt to cognitively understand things that he couldn't understand, and this was something he could understand. Let's fix so I don't have to go to the bathroom 5 times a night and I'll be better, even though that really little to do with the TBI. Whether it was a depression-related somatoform disorder, or even perhaps a conversion disorder, where on a psychological basis, the neurological, emotional trauma the person was experiencing was being projected into this one symptom, which then became the person's focus, which was very disruptive to treatment because I suggested a number of different things, and not only treatments, but even just neuropsych testing. And he said, well, use plain language, how is that going to affect how I pee? So you need to be aware that when those defenses take a certain intensity, they have to be dealt with first at times before you could get to the other issues, which is just another complicated ball of wax. In terms of the PTSD, I noticed obviously the psychosocial history in terms of abuse, trauma, whether it be intentional or whether it be accidental, or whether it be just having viewed a traumatic situation. And one of the issues I'll bring up here, because it's often neglected, is domestic abuse. The number of people who I have seen, and whether they're coming in for anxiety, depression, or due to an acute TBI, who basically had a history of domestic abuse, typically women, obviously, but no one bothered to ask if they had concussions, because the psychologist was focusing on getting out of the relationship or doing what needs to be. The medical doctors were looking at the physical injuries. No one was really asking how many times did you see stars. I had one particular case. It was a workers' comp case not that long ago, and it actually didn't involve TBI, but involved neurological problems, supposedly related to toxic exposure. I won't go into detail. No one could make heads or tails of these person's symptoms until we took a history and found out that one probably had ADHD and ADD as a kid. They had some problems developmentally growing up. And the woman had been in two marriages to violent alcoholics. And when I asked how many times did you see stars, he said, I can't count the stars and I can't count how many times I saw them. Yet that was never taken into account in trying to understand what the possible toxic exposure is doing neurologically. And once again, and I know I'm repeating myself, this goes back to needing to carefully and consistently and regularly integrate care among all of the specialties. Because if you miss something, that issue is going to take a life of its own and may negatively impact everything else. Um, and obviously, taking a complete psychosocial history, you need to look at both the person's life circumstances, their support system. Do they have a support system? Is it useful? Are they someone who's rather avoidant and is used to just taking care of themselves and that's being disruptive? Or are they in a somewhat toxic situation? Or do they have other people depending on them who they no longer can support? Part of my work is practice is up in the Central Valley of California, and I'll see a good number of field workers who suffer head injuries. And one of the most significant psychosocial issues is they can no longer send money back home. They're not working, they're getting a paltry disability, maybe, and they can no longer not only support their family in their home, but their family somewhere else or in another state or even in another country. And that can lead to a severe loss of self-esteem, loss of sense of usefulness, and at times toxic reactions from others who don't understand. So do not underestimate not only formal PTSD, but just sadness, loss of sense of purpose, fear, and of course, most dangerous, despair, because that leads into the serious depression that can lead very easily, particularly in the person who isn't thinking very clearly, to they'd be better off without me. And anyone who's worked in this area heard that innumerable times, uh, sometimes seriously and sometimes, well, it's something that crosses my mind, but I wanted to act on it. But even when I say I wanted to act on it, you never know what additional factors may lead to their crossing that threshold. And that bears continual vigilance in terms of psychosocial factors, medical factors, obviously substance abuse factors. And the other issues that are related but somewhat different are the person's underlying personality dynamics, as I already spoke about. Is this an intense individual who does everything very intensely, and if they can't maintain that level of intensity, they feel totally incompetent? Are they used to functioning with an adaptive obsessionality that either they cannot reach or they overemphasize? How is it affecting motivation, social skills? Um, One of the things I deal with a lot in athletes, first responders, law enforcement personnel who have TBI or who have depression for that matter, is that these are people who often chose their profession because in lay language, they like running on adrenaline. They like the rush. They miss it if they can't get the rush. You take that rush away from them, whether it's due to the neurological effect of the TBI, whether it's due to depression, whether it's due to medication, which is very common with some of the antidepressants that I'll get into in a little bit. The loss of that ability to experience excitement can be devastating and can also affect how that person then interacts with friends, family, colleagues, whether it's avoidant, whether it's being angry, whether it's being irritable. Obviously, it could go in any direction, as well as whether the friends, family, and colleagues are understanding and supportive, or toxic, hostile, or just simply not understanding. Um, Different types of therapy. I'm not going to say anything about each of these specifically. What I will say is everything has to be tailored to where the person is at the moment, and what may work at one point may not work at another point. For instance, psychodynamic therapy or existential therapy may not work when the person's in a state of acute cognitive impairment, which may fluctuate. Even cognitive behavioral therapy, if the person forgets what to do, you can train them over and over, it's not going to work. So which type of therapy has to be basically reevaluated, both on a large basis of what protocol, what treatment program, but also day to day, week to week, sometimes even minute to minute within a session. Which brings us to another issue, which I'm just going to talk about generally, is the quality of the therapist. I mean, in general, there are good therapists, there are bad therapists, there are good psychiatrists, there are bad psychiatrists. I won't get into my personal opinions as to how the mental health system has deteriorated over the past 40 years and how training has become more technical, but less humanistic and less effective. But also, many psychiatrists, many therapists do not have experience with TBI-related disorders, don't understand what we've just been talking about, don't realize that they're going to have to think outside the box because the intervention that worked last week may not work this week. So again, you need someone who's experienced, you need someone who's sensitive, and you need someone who isn't afraid or hesitant to get advice from others and to carefully integrate their care with other practitioners. The number of times I'll see therapy notes when I'm doing a workers' comp eval and I get all the records, and the therapist doesn't even have an idea what medications the person is on or what the side effects, the minor side effects may be. A person may have mentioned major side effects, and the prescribing psychiatrist has no idea who the person really is other than what medications they're taking. So quality of the therapist, understanding of the therapist, the willing of the therapist to integrate their treatment with other mental health practitioners, as well as other medical psychosocial practitioners. And again, this is just talking about the different types of intervention that may be used. And again, different interventions at different times, depending on what the symptoms are and the person's ability to make use of the interventions at that time. And just sort of closing, I'm not going to go through all of the medications and all of the pluses and minuses, but every medication we use that can be effective post-TBI, post-concussion, also may have pitfalls. As I said, the antidepressants, the SSRIs, the SNRIs, can dull cognition, can cause emotional flatness. Drug companies will say they cause sexual dysfunction 10 to 20% of the time, unless I have a very weird 15,000 person history of patients I've treated, it's more like 70% of the time. Anti-anxiety agents, obviously, they can be addictive. They inherently can cause memory problems, other than perhaps I'll use a lot of Buspar because that tends not to. They're fast, they can be effective, they can be used as needed, but long-term use can be very problematic. The other side is stimulants, which can be very helpful when you're dealing with someone who is having problems with cognition and sort of an ADHD, ADD type presentation. They may react very well to stimulants. Even their depression may react to stimulants. Stimulants do have an antidepressant effect and don't have the flatness, but they can cause overstimulation. They can cause anxiety. They can increase paranoia, and there can also be the issue of dependency. Mood stabilizers, I won't go into detail because they basically involve all of what I've just discussed. But one other interesting thing is that another reason why treatment has to be well integrated between the psychiatrist, the psychologist, and the neurologist. One person I'm thinking about who I was treating with post-concussive issues and then developed seizures out of it. And I had tried a number of medications that had not worked particularly well. The neurologist put the person on Lyrica for seizure control. Lo and behold, their mood improved dramatically because Lyrica is a mood stabilizer. So again, integrated care, thinking out of the box, and being willing to have educated trial and error to see what does work and what doesn't work. Just to summarize, the human body isn't a machine. The brain is not a digital computer. Uh, and the input is multiple, the output is all over the place. We have dependent variables. I like to, when I'm working with people, use the metaphor that we're dealing with both your hardware and your software. And obviously they're intricately related. The software won't work if there's damage to the hardware. Excellent hardware will be useless if you have pitiful software. So we're dealing with all of this simultaneously and in a constantly changing manner that is not going to be defined by statistical averages or algorithms, but we need to recognize and work with the inherent instability and chaotic functioning of our very complex bodies and minds, especially minds when there are injuries, an injury to the brain. No one size fits all treatment is available. Treatment efficacy changes over time and over time frames of minutes to hours to days. And what worked one day may not work another day. We need to closely monitor people, think outside the box, be willing to change things, be willing at times to tweak medications in ways that we may not know if it's placebo or not, but damn it, if it works, it's good. If it doesn't work, it's bad. Uh, Along with that, individualized treatment to the person's life circumstances, and again, judicious trial and error depending on all of the above. Uh, Basically, this is just repeating what I've just said, and I think I'm going to leave here with just some information on Alaskan and national mental health resources that will be available. And also will be available are some of the references that I've used in some of my slides, and particular to the resources that there. I'll close with one other case study. And this actually was a head injury case. It was a workers' comp case here in California. Person was a caretaker, and she basically, one of the patients she was working with attacked her. And the way she put it, the way she described it, is the person just got agitated, started rocking back and forth, started accidentally headbutting her, but then got a kick out of headbutting her and repetitively headbutted her until she had a clear concussion. It was obvious she had a concussion with acute symptoms. But over the next several months, the symptoms increased, which is not all that usual. It wasn't a real severe TBI, but also became rather dramatic and unusual, rocking back and forth, burping, gasping for air, great sensitivity to sound and light that suddenly came up, and the person wouldn't go out without earplugs, none of which we could understand until we really took a good history and found one significant amount of access to pathology. The person may not have qualified for chronic PTSD or borderline personality disorder, but those traits were there. And when we got the old records, found that they had been diagnosed with ADHD and PTSD as a teenager, that they had never made a suicide attempt, but they were brought to the doctor. It was documented approximately 15 times for setting up suicidal scenarios, but then not going through with it, but did have a history of self-burning at ages 12 through 14. Now, how much of that was reawakened, played into by the TBI that then set off everything running in a different direction, and that would not respond and did not respond to a very specific neuro rehab program the person was involved in that was only looking at their neurological cognitive issues and not realizing how much the cognitive issues may have been coming out of a chronic PTSD. I'd like to thank everyone. I could have gone on for a couple more hours. This is such a, to me, interesting, at times rewarding, at times tragic, but very necessary area for study. And please feel free to reach out to me. My contact information will be available. Thank you very much.